Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 412 of our pharmacotherapy series, which majors in lower gastrointestinal disorders. This clinical case involves patient TAC from parts 410 and 411 of this pharmacotherapy series. TAC feels much better and claims to be back to normal. Her abdominal pain is gone, and she currently has 2 formed, non-bloody stools daily. Most of her laboratory parameters have returned to normal. That is an erythrocyte sedimentation rate abbreviated as ESR of 19 mm per hour. Blood glucose of 95 mg per deciliter. A WBC of 8,300 per microliter. She is currently taking mesalamine 800 mg orally thrice daily. So my first question to you reads: what drug regimen should be used to maintain disease remission in TAC? Aminosalicylic acid agents significantly reduce the incidence of relapse in ulcerative colitis patients who are in remission. At 12 months, 65% to 70% of patients remain relatively symptom-free compared with placebo. As discussed previously, the anatomic site of disease is an important consideration in the selection of a 5-aminosalicylic acid preparation. Data also suggest that, if tolerated, higher doses have higher rates of treatment success. In contrast, oral and topical corticosteroids do not prevent relapse of ulcerative colitis once remission has occurred. On the basis of this information, JAC's mesalamine should be titrated to a total dose of 4.8 grams in divided doses. If she experiences a relapse, a course of oral corticosteroids may be needed to re-achieve remission. Prophylactic therapy should be continued indefinitely unless intolerable adverse effects develop. This is especially true in light of data that suggest that long-term mesalamine may be chemoprotective against colon cancer. TAC's mesalamine has been increased to 1,200 mg thrice daily for ulcerative colitis maintenance therapy. Several days after starting this higher dose of mesalamine, TAC experienced anorexia, nausea, and epigastric pain. So my question to you is: what is the possible cause of TAC's symptoms? How can they be minimized? TAC appears to be experiencing adverse effects of mesalamine. Although usually better tolerated than sulfasalazine, unwanted adverse effects occur in 10% to 45% of patients. Most 5-aminosalicylic acid adverse reactions are dose-related and tend to occur early in the course of therapy. Dose-related 5-aminosalicylic acid adverse effects can be minimized by initiating the patient on a low dosage, that is 1 to 2 grams per day, and gradually increasing the amount to tolerated therapeutic doses. If dose-related reactions do occur, the drug should be discontinued until the symptoms subside. Then it may be reinstituted at a lower dosage. TAC's symptoms are probably dose-related adverse reactions to mesalamine. The dosage should be decreased, or the drug temporarily withheld. If tolerated, the dosage can be increased slowly as necessary, or she can be switched to another agent to maintain disease remission, such as an immunomodulator. TAC's dose of mesalamine was decreased to 800 mg thrice daily. After 2 weeks, TAC continued to have nausea, diarrhea, and headache severe enough to cause her to miss classes and call in sick from her part-time job. Objectively, she has lost 5 kilograms, and now weighs 46 kilograms, in the last week as a result of anorexia and nausea. So my next question to you reads: what alternative therapies should be considered at this point? The results of several trials suggest azathioprine and 6-mercaptopurine are appropriate alternatives for patients with active ulcerative colitis that have not responded to systemic steroids, although their actual level of effectiveness is debated. These drugs are also used to maintain remission, although they are probably used more in Crohn's disease than ulcerative colitis for this purpose. Infliximab, adalimumab, and vedolizumab are approved in the United States for moderate to severe ulcerative colitis, both for induction therapy and for maintenance of remission. Because of significant costs and adverse effects, they should be reserved for patients with refractory disease. Cyclosporine, abbreviated as CSA, has also been used to treat active ulcerative colitis. In one retrospective review, IV cyclosporine had a roughly 50% response rate even 2 years after acute therapy. Many drug interactions and adverse effects are associated with cyclosporine: hypertension, gingival hyperplasia, hypertrichosis, paresthesias, tremors, headaches, electrolyte disturbances, and nephrotoxicity are common. In TAC, a reasonable choice would be azathioprine 115 mg, that is approximately 2.5 mg per kilogram per day. Monthly monitoring of WBC counts and liver function testing, as well as periodic assessment for any signs and symptoms of pancreatitis, would be appropriate. 1 year has passed since TAC last had an acute attack of ulcerative colitis. She has been taking azathioprine dosed at 2.5 mg per kilogram per day. Today she presented to her primary health care provider for her annual physical examination. She asked about receiving the yearly influenza vaccination as well as the pneumococcal vaccination she has been reading about online. Her primary care provider is unsure whether TAC is a candidate for either vaccination. So my question to you reads: should TAC receive both vaccinations? What vaccinations, if any, is TAC a candidate for? Immunomodulators and biologic drugs are the mainstay of inflammatory bowel disease treatment. However, one of the most important adverse effects are infectious complications. As mentioned above, serious and sometimes fatal infections have been reported with drugs such as azathioprine and infliximab. Some of these infections are preventable with immunizations. Unfortunately, data exist that immunization strategies are significantly underutilized in the inflammatory bowel disease population. Guidelines recommend that standard immunization schedules be adhered to, that serologic testing for varicella be performed on inflammatory bowel disease patients without a clear history of chickenpox, and if negative, such patients should be vaccinated against this virus, and that live virus vaccinations should be avoided in patients, such as TAC, who are receiving azathioprine. Specifically, concerning TAC, she should receive the seasonal influenza vaccine as well as the 23-valent pneumococcal polysaccharide vaccine and hepatitis B vaccine. Many patients with inflammatory bowel disease would also be candidates for the human papilloma virus vaccine, and given the increased incidence of abnormal Papa Nicolau tests in this population, this would be a reasonable strategy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 413.